Dr. Tzifa will now introduce the discussants. We have a little bit of time, but not as much as we might have liked.
Yeah, so thank you to all the speakers. We had wonderful lectures. We've got with us two discussants, Dr. Loukopoulou Sophia from Hagia Sophia Children's Hospital, who is a pediatric cardiologist and also a senior pediatric cardiologist here in Greece, Dr. Dimitris Daskalopoulos. So thank you both for being here with us. Let's open the discussion and then we'll take any questions that we have from the attendees. Thank you.
Do you hear? Good morning to everyone.
Yes, all fine,
Yes,
Sophia. Thank you.
Okay, good morning. I would like to thank the organizing committee for the kind invitation, especially you, Ms. Tzifa and Mr. Mitropoulos, and the presidents, Professor Anderson, Professor Yiannopoulos, for the kind invitation. I would like to give everyone congratulations. It's amazing. It's an amazing Congress. All the presentations were excellent and very, very interesting. They give us new information about the PDA closure for the preterm infants. As I am a neonatologist too, I would like to remind you that the neonates, the preterm neonates, have other problems from the brain, from the gut, the nerve function. And so it's very, very will be a salvation solution for them if we have a transcatheter closure. The surgical ligation often has a lot of problems, and after the surgical ligation, we have serious problems, especially with the lung compliance. That preterm babies, as you know, have very, very, very problems with the lung compliance. I would like to inform you our experience from Hagia Sophia Children's Hospital Hemodynamic Laboratory concerning the critical stenosis in neonates. First of all, Aphrodite, I would like to give you congratulations for the rapid ventricular pacing. My ex-director, Mr. Thanopoulos, and now with Mr. Eleftherakis, with all the neonates with critical neonatal stenosis who have balloon valvuloplasty, we use the rapid ventricular pacing. We have the best results. And I would like our patients who have the right, when we select the right patients, the right neonates for balloon valvuloplasty, I think we have the better results. When they are the valve is dysplastic, not the very, very dysplastic, but very dysplastic without regurgitation, we have very good results. When we have the right size of the balloon, and the right type of the balloon, it's very important. We have 12 to 5, I have now 12 children who underwent balloon valvuloplasty when they are 20 days old. Now they are 14 years old, and they have no intervention, and think that's because of the good, it was the right patients and the right technique. Concerning now the critical PS, the balloon valvuloplasty is very safe too, and it's very, very, we have patients with a small RV, and now after the balloon valvuloplasty, they are in the early childhood, they have significant growth. So we can give them to the smaller V with critical PS, neonates with smaller V with critical PS, will balloon valvuloplasty, maybe we'll have the hope that the RV will grow. I would like to ask now Mr. Mitropoulos, what do you consider the safest method in your daily practice for the babies, for the neonates who have the coarctation repair?
Yeah, I think as our practice has evolved, we have been using antegrade cerebral perfusion with moderate hypothermia in the majority of the cases, and less often deep hypothermic circulatory arrest for this kind of pathology.
Dr. Daskalopoulos, may we have your comments, please?
Thank you.
You are hearing me now?
Yes, that's great.
All right. Thank you. Good morning, everyone. I feel happy to be part of this. I've learned a lot. Right now, I'm a little worried that we're invading into the next session, and that's not going to be fair. A quick question for Dr. Alain Fraisse, if I may. I don't have any personal words of wisdom to contribute to this session, but Dr. Fraisse, I enjoyed your talk along with your paper in Frontiers of Pediatrics last September. And my main question is your admirable method of closing the ductus in premise is where you work right now. I assume you're at the Royal Brompton Hospital.
Yes.
Is it a first-line approach, a first-line treatment, or you choose it instead of surgical closure when everything else fails?
No, that's a very good question. We have, I think our last surgical ligation was in 2017 for the baby who had this IVC dissection. But other than that, we don't perform. Since we have started this program, we have stopped performing surgical ligation. Those babies, importantly, are still discussed, are still presented in the medical surgical meeting, but they are presented very quickly because we want also the surgeon to be aware, even if I would say rescue surgery, especially when these babies are very small, would be extremely difficult. We continue to involve the surgeon, and we moved from one period at the beginning. We were discussing jointly the consent with the parents. We are giving the choice between surgery and transcatheter intervention during the first 20 cases in 2016 to 17. And then, to be clear, we have had a great support from the surgeon. So all the parents were really choosing transcatheter intervention. Our surgeons were believers of this technique, and we are very grateful for that as well. And then we carry on. We just offer only transcatheter closure, but still discussing the babies with all the team. That's my answer to this.
Thank you. Thank you very much.
That's great. Thank you very much. Just a small comment on my behalf. With a critical pulmonary stenosis of small right ventricle, it's also a very passionate field because we want to recruit these babies as quickly as possible, as early as possible, in order to have biventricular circulation. So we don't so much do RV echo area these days. We have MRI, and I just wanted to point out MRI is a procedure that you can do very safely in neonates and in infants, and you can do sequential MRIs. You don't have to give gadolinium every time. We know about the gadolinium deposits in the brain, etc. We don't know their impact so far, but MRI is definitely the method to go to assess the right ventricle, if it's borderline, sequentially over time with the PR that we are causing and the growth of the right ventricle. So thank you very much all. We're going to close this session now, and we're going to move to the next ECMO session. Thank you so much for being here with us. We're going to have a few seconds break, and then we're going to move to the next session.